so continuing with our Renin-Angiotensin-Aldosterone Mechanism. My cell phone only goes so long before it stops with recording. Sorry. Okay, so going back to angiotensin 2, which is the vasoconstrictor, so making your blood vessels a whole lot smaller. So constricting the efferent arteriole, so the one that exits out of the glomerulus, and therefore preventing the flow of fluid from going too fast. Major league absorption for sodium chloride, sodium, as well as water in different parts of your nephron loop, as well as promotes water absorption, so helping to raise your blood pressure by increasing the water in the blood and therefore causing more pressure in that blood vessel. Stimulates thirst, so again, more water coming into your system, therefore more water available to the blood, so to increase your blood pressure. So in general, angiotensin 1 restricts blood flow as well as increases blood volume through these mechanisms, and that therefore both of these will increase your blood pressure. Okay, time to make some urine. So first step is you have your blood filtered in the glomerulus in the renal corpuscle. So blood flow in and then right back out, creating your filtrate. So that's your first step. So you're going to go from the glomerular filtrate to eventually being produced as urine out of your kidneys. So the whole process, you filter the plasma, and then there's a back and forth exchange between the tubule system as well as from your capillary. So exchanging, taking back what's useful to the body, and then sending the waste, into as part of your urine. So the steps include your tubular reabsorption, so reabsorbing stuff from the filtrate that's useful to the body. Tubular secretion, getting rid of stuff from the blood that is no longer necessary for the body and therefore waste. And then final step, water conservation, to again conserve the water that you have in your body as well as concentrate your urine. So first step, tubular reabsorption. So there's a transcellular route, so going straight through the cells. So stuff that is lipid soluble can pass through those cells. Or the pericellular route, so going through the gaps in between those epithelial cells. So the fluid can take whatever's dissolved in it and drag it through. This reabsorbed fluid is ultimately taken up by the peritubular capillaries. So stuff that we actually want to keep in the body gets reabsorbed from the filtrate in the tubules and then taken back up into those peritubular capillaries. So in order to have your tubular reabsorption, the main key player in that is sodium. So earlier we talked about how sodium gradients are used for example, your different action potentials, and that gradient, when the sodium is allowed to go down its gradient, helping to create different changes within the cell. The gradients that are set up with sodium, and we talked also with this for digestion as well. So it creates osmotic and electrical gradients that help to drive the reabsorption of water and other solutes. So steep concentration gradient favors this diffusion into epithelial cells. So again, you're going down your concentration gradient. So when it does go down its concentration gradient, other mechanisms, so other carriers, help to use this concentration gradient to move other solutes from the filtrate and back into the blood. So for example, you have symports that will bind to the sodium, taking the sodium down its concentration gradient, but also binding to something else to also take it down its concentration take it in the same direction down the concentration gradient of sodium. So the symport's going in the same direction. So bringing sodium and glucose with it, or if it's sodium and an amino acid, or sodium and lactate, bringing it from the tubular fluid and back into the capillaries using that sodium gradient that was set up. This actually works in the opposite direction, so taking sodium down its concentration gradient still, but pulling hydrogen ions into the tubular fluid. So we'll talk about that later when it talks about acid-base balance. So these are going in two different directions. So sodium out the tubular fluid, hydrogen into the tubular fluid. So we've already beat this dead horse about your sodium-potassium pumps. So this helps to pump out the sodium back out the cell and pumping in potassium into the cell. So that again helps to set up that gradient so you can bring more stuff into those endothelial cells and help move them, move those solutes back into the peritubular capillaries. So other examples of how sodium is used, and this first example has to deal with, instead of just your concentration gradient, but also the charge difference set up by sodium. So as your sodiums are moving down their concentration gradient, so you have this nice positive ion, the negative chloride ions are attracted to those positive sodium ions and therefore will follow sodium into the cell. Other routes of transport, you have potassium, magnesium, and phosphate will go through solvent drag, so going in between the cells, and allows those ions to move from the tubular fluid through those epithelial cells that make up the tubes and into your peritubular capillaries. Some calcium is reabsorbed, same type of paracellular route, so through leaky tight junctions. And then early talked about this, your glucose being co-transported with sodium, so going down its concentration gradient, and therefore helping to pick up glucose because our bodies still want it, as in, hey, this is energy, we can't lose this, bring it back into the cells. So most of it's actually reabsorbed from the tubular fluid, so the fluid that's inside those tubes. Okay. So the next slide has just kind of a picture version of showing it, which kind of really breaks down and shows stuff very easy. So you have your solvent drag bringing stuff through in between those endothelial cells. You have your sodium glucose symport bringing sodium down its concentration gradient, so being higher on the outside of the cell, bring it into the cell. Sodium hydrogen antiport, so going opposite directions. Chloride and other anions are going through antiport, so this one's actually attracted to the sodium going down its concentration gradient. Aquaporins, so actually comes a little bit more important later, but again, bringing in that water that our body wants to reabsorb, bringing it back from that tubular fluid so that we can, so that we can conserve the water that our body has. So here at the opposite end, again, you have your sodium-potassium pump, setting up those gradients, so pumping sodium back out the cell, bringing potassium back in. This is active transport using up ATP. You have glucose transport, just its own transport going out of the cell so that way it can go right back into your bloodstream. And then a potassium chloride symport, so chloride comes in, being attracted to sodium, then potassium, that sodium-potassium pump setting up that gradient, so you have higher potassium on the inside of the cell. So taking potassium down its concentration gradient, chloride also is electrically attracted since this is positive, and pushing it out of those endothelial cells so they can be absorbed into the capillaries. Okay, focusing now on water. So I mentioned earlier water going into those endothelial cells through the aquaporins. So when you have your glomerular filtrate and it's going through the tubes, so your proximal convoluted tube through your collecting duct, body reabsorbing that water so that it conserves it. The water follows the solutes through osmosis, so both through paracellular and transcellular routes, as well as the aquaporins. So transcellular is the aquaporins route in your proximal convoluted tube, so the first one right off that renal corpuscle or glomerulus. There's a obligatory water reabsorption, where you just have the water that's reabsorbed there. The peritubular capillaries reabsorb water that leaves the basal surface of the tubular epithelial. So you remember our cell where we had, here's the, say if this was the tube, and then these are the endothelial cells, so bringing the water back out. So it's through osmosis and solvent drag. So there's 3 factors that promote osmosis of water into the capillary. So we've gone from the tube through the endothelial cells, and now we're into the capillaries. So high interstitial fluid, that helps to push against the capillaries and therefore driving fluid into the capillaries. A low blood hydrostatic pressure, so low blood pressure, helps to have less force countering fluid coming into the capillaries. And then a high colloid osmotic pressure of the blood. So if you remember earlier, you have your blood filtrate in the glomerulus. What doesn't filter out are your red blood cells, of course, as well as the proteins that are in your plasma. And since you have such a high concentration of proteins in the plasma, due to that a lot of your plasma getting filtered out but still leaving the proteins behind, you end up with a high colloid osmotic pressure, and therefore drawing fluid, so drawing that water from the tubular fluid and back into the capillaries. So this is just a picture version of it, how your angiotensin II, so the one that we talked about earlier, how it controls blood pressure, helps to maintain your blood pressure as well as the glomerular filtration, reducing that blood pressure in the peritubular capillaries, so less pressure is pushing fluid out the capillaries, which helps to draw water from the tube and back into the capillaries. So helps to concentrate your urine and decrease the urine volume. So now moving on to tubular secretion. So instead of taking stuff from your tubes and bringing it back into the capillaries, we're now taking stuff from the capillaries and secreting it into the tubular fluid. So taking it out from the blood, even though we've already did our first step of blood filtration, now we're going to take some more stuff out the blood. So the purposes of your tubular secretion are for your acid-base balance. So different hydrogen and bicarbonate ions help to regulate pH, helps with additional waste removal, so secreting from the capillaries anything that didn't get picked up the first time, allows it to be secreted into the tubule and therefore being sent out as waste, and also helps with the clearance of different drugs and contaminants. So again, what didn't get filtered the first time helps to bring that from the capillaries into the tubular tubes and therefore excrete it out as waste. So for example, some of your medicines that have to be taken multiple times a day is because your kidneys are filtering it out, and so you don't have that drug flowing through your bloodstream, and therefore you're not having the desired effect. So one major part of the tube that has to deal with this is your nephron loop. Primary function of it is to concentrate the urine and conserve water. So a lot of water movement in the nephron loop. So part of this is reabsorbing some of the electrolytes. So we're now taking electrolytes from the tube, reabsorbing it into the capillary. So there's two segments in your nephron loop. The thick segment is very permeable to your electrolytes. The thin one is more permeable to water. So first step, nephron loop. So we're going down our little nephron loop. That's your thick segment is the first part, reabsorbing those electrolytes. So taking it out of the tubular fluid. So it makes the filtrate very dilute as it goes into the distal convoluted tube. And that helps with the water absorption. So thick segment reabsorbs a bunch of the different electrolytes. That's because it's not permeable to water. And then your thin segment, talk about later how that allows it to bring water into the cell, and then as well as you go into the distal convoluted tube. So once you get to the distal convoluted tube, there's about 20% of the water initially, as well as 7% of the salts from the glomerular filtrate, but still needs to be concentrated even further in your distal convoluted tube. So its main job is to reabsorb a lot of your water as well as your salt. It's regulated by your different hormones. So again, your aldosterone hormone, so part of that Renin-Angiotensin-Aldosterone system, atrial natriuretic peptides, which helps with water absorption, ADH, as well as your parathyroid hormone helps to regulate its activity as well. So the main hormone that really does a major job in affecting the tubes is your aldosterone hormone, also known as the salt-retaining hormone, so very important one. It's secreted by the adrenal cortex, so from the adrenal glands that sit on top of the kidneys, for the most part, unless your kidneys are in a different spot than they should be. So the triggers for secretion of this hormone is when your blood sodium levels fall. So therefore, this hormone secreted, causing more salt to be retained, and therefore helps to increase the concentration of your sodium. Also triggered when your potassium concentration rises. So they kind of, like your sodium and potassium, they kind of work in opposite each other. So this will help to get rid of the potassium and therefore reduce those levels in the blood. And also if there's a drop in blood pressure, which signals the renin release and eventually get to your angiotensin-2, which will then secrete stimulate the adrenal cortex and secrete your aldosterone. So retain the salt into your in your blood, therefore increasing the blood pressure, not only because you have more salt in the blood, but also because you have it increased the osmolarity of the blood, so now you have more water getting into your blood vessels, and therefore you're having more things inside the blood that helps to increase your blood pressure. So again, net effect of aldosterone, which is your salt-retaining hormone, here in red. The net effect is that the body retains sodium chloride and water, helps to maintain blood volume as well as blood pressure, and reducing your urine volume. So the opposite of this is your natriuretic peptides. So this is where you have high blood pressure, so need to reduce it. So the opposite effect of aldosterone. So instead of retaining salt, you'll excrete more salt, therefore also excreting more water into your urine, therefore reducing your blood volume, which also drops your blood pressure. So the next hormone that affects your urine production is your antidiuretic hormone. So this is in cases where you are dehydrated, you have a low blood volume as well as a rising blood osmolarity, so still needing more water to come back into your blood. So when this hormone is released causes water and the tubular fluid to re-enter the tissue fluid and bloodstream rather being lost in urine. So going from your tubes back into your blood vessels, and therefore increasing the blood volume, increasing the water in your system, and therefore reversing your dehydration, reversing your loss of blood volume, and helps with your blood osmolarity by helping to dilute the solutes that are in the blood. Okay, last hormone involved is your parathyroid hormone made by the parathyroid gland. Again, something that you covered in AP1 near the end. So this affects your, if you have like a calcium deficiency, so helps to increase your phosphate excretion. So I can't remember if we covered this somewhere. But one thing that these two molecules, your calcium and your phosphate, they like to bind together. So part of it making one of the minerals in your bone. So your body tends to keep them separate. So your calcium usually is either pumped out of the cell or sequestered in the endoplasmic reticulum, and then the phosphates are just in the cell. So it acts on your proximal convoluted tube, so the one near the glomerulus, to increase phosphate excretion. Acts on your distal convoluted tube to increase calcium reabsorption. So getting rid of your phosphate and allowing for more calcium to be reabsorbed. So this helps your calcium stay in circulation, so keeping the phosphate away from the calcium so that they don't precipitate or form, kind of in a sense like the bone crystals that make up the minerals inside your bone as calcium phosphate. So essentially keeping them together so they don't form a crystal. Keeping them separated so they don't form a crystal. So getting rid of the phosphate, keeping the calcium, then that way your calcium's still able to be free-flowing versus being stuck to phosphate. So last step in our tubular system is the collecting duct. So it receives different tubular fluid from several nephrons. So your nephron starting from the renal corpuscle with the glomerulus where you filter the blood, then moving to the proximal convoluted tubes, nephron loop, distal convoluted tubes, and then entering into the collecting duct. So you have multiple of those nephrons dumping into that one collecting duct. So into multiple nephrons into one duct. So the collecting ducts runs through the medulla, which is the more internal portion of your kidneys, to help reabsorb water and helps to make urine more concentrated. So the medullary portion of the collecting duct is more permeable to water than sodium chloride, so allowing for that water to exit from the collecting duct and back into the tissues. So water leaves by osmosis as the urine passes through the medulla. So as it goes through the medulla, it becomes more and more salty, and therefore increased levels of osmolarity, pulling water out of the collecting duct and helping to increase the urine concentration. So picture version of it. So here we have our osmolarity of the different portions. So here in the cortex, it's only about 300 milliosmoles per liter. But then as you go down the medulla, it becomes increasingly more, has more higher concentration of solutes. So this allows for even more and more water to exit out of that collecting duct and concentrate the urine. So brings that water back into the tissues and allows the body to reuse that water. So depending on how hydrated you are determines how much water is going to be reabsorbed from that collecting duct. So for example, if you tend to drink a bunch of water throughout the day, you end up having what's called hypotonic urine. So there's not much in your urine because you have a lot of water excess that your body needs to get rid of. So this is where you kind of go to the bathroom and your water kind of looks like that light, very light lemonade color. So very, not much in the urine. It's mostly a fair amount water. So in this case, the salt is removed from the urine, but the water tends to stay in. So the water stays in the urine, has a very low concentration of solutes. So this is water diuresis. Opposite is your, when you're dehydrated, end up creating hypertonic urine, so having a lot of solutes. So this is where you have your, I don't say richer, but darker colored urine because there's so much stuff in there. Your body's trying to pull as much water as possible, so your urine becomes more concentrated. Your blood has high osmolarity because you don't have enough water, so it stimulates the release of ADH hormone and therefore increases the level of aquaporin channels in the renal tubule cells, and therefore allowing for more water to be reabsorbed by the collecting duct. So just allowing more passageways for water to reabsorb as much as possible, and therefore urine becomes more concentrated because you're taking out even more water away from the fluid inside of the collecting duct. In a case where someone has a low blood pressure as well as being dehydrated, so loss of fluid from being dehydrated, so therefore lowering the blood pressure because that fluid is no longer in the blood, so the lack of water from that area. Decreases the GFR, so it gives it more time for reabsorption, so less flow through your nephron, more time to reabsorb, particularly your water, allowing for more salt to be removed, as then, of course, more water should be absorbed, and therefore less urine is produced, so less loss of fluid from your kidneys.